Hello, I'm Jim Smyrniotopoulos, and we're going to be talking about extraaxial non-glial masses. I have no significant financial disclosures to make. We're going to be talking about chordoma and various epithelial cysts. All of the lesions we're discussing in this talk are derived from ectoderm. Our educational objectives. Chordoma is a destructive lesion that arises within bone from ectodermal remnants of the notochord, primarily affecting the clivus and the sacrum. Epidermoid cysts are ectodermal inclusions, most commonly in the cerebellopontine angle, and they consist of a mass of dead skin flakes. Dermoid cysts are a more complex midline mixture of skin flakes, hair, and sebaceous oils. Arachnoid cysts are water balloons, most commonly in the middle fossa near the temporal lobe. Colloid cysts are almost invariably in the anterior third ventricle. Their lining is like endoderm, and they produce mucus. Craniopharyngioma is a heterogeneous suprasellar ectodermal cyst. And we're not going to have time to talk about Rathke-Cleft cysts. So let's start with chordoma. The chordoma is a non-mesodermal, non-sarcoma primary bone tumor. It arises from ectoderm. This can be shown histologically as well as embryologically. The primary locations for the chordoma are in the clivus and the sacrum. If we look at this sagittal reformation, we look for the normal cortical outline of the clivus, and we can see that it's been eroded away. There's been some bone destruction here. So we have a destructive lesion of the clivus. If we look at the MR imaging, we can see a soft tissue mass arising within the bone and bulging back as an extradural lesion, pressing on the pons and the basilar artery. And we can see that the lesion lacks a blood-brain barrier and shows heterogeneous contrast enhancement. Because chordomas are midline lesions, they typically cause bilateral cranial nerve palsy, most commonly 6th nerve palsy. The normal clivus is shaped like a wedge or like a doorstop. In fact, the term clivus comes from the Latin word for hill or wedge or slide. Chordomas originate from remnants of the embryologic notochord in the midline. They produce lobules of neoplastic cells and a watery myxoid matrix, which accounts for their high signal intensity on T2 and relatively low signal intensity on T1 weighted images. They're classically associated with dystrophic calcification and with fragments of the parent bone persisting as sequestra within the tumor. Chordoma is a relatively uncommon tumor. It's anticipated that approximately 25 people will be diagnosed in the United States every year. Chordomas do account, however, for a higher percentage of all bone tumors, and they represent 20% of primary spinal bone tumors, most commonly in the sacrum, but also in the cervical spine. So where do we find normal notochordal remnants? The nucleus pulposus of the intervertebral disc contains notochordal cells, but is almost never the site of a neoplasm. A small percentage of normal people also have a remnant of the notochord as an intradural mass right behind the dorsum sella. It's about the same size and shape as a grain of rice, and it's in front of the brainstem. This is called the Echordosis physaliphora. Usually the Echordosis physaliphora is relatively small, but in this rare example, we can see a very, very large gelatinous mass that was intradural and retroclival. The differentiation between the Echordosis physaliphora and a neoplasm is relatively simple because the echordosis is usually asymptomatic and does not show contrast enhancement. They're going to be hypointense on T1, hyperintense on T2, and again, no contrast enhancement. Benign intraosseous notochordal remnants, not neoplastic masses, are found relatively frequently in about 20% of patients in an unselected autopsy series. They're seen almost equally as remnants in the clivus and remnants in the sacrococcygeal region, and they're almost never seen in the thoracic spine. We don't know exactly why they're so uncommon in the thoracic spine, but perhaps the abnormality in the thoracic spine would not be associated with a viable embryo or fetus. The classic histology includes these bubble or vacuolated Physaliphorous cells. Physaliphorous means bubble-bearing cells. They're again most commonly seen in the sacrococcygeal area. About half of chordomas arise there, a little bit more than a third in the clivus, and in the axial skeleton, about 1 in 7 occur in the vertebral bodies of the cervical spine. Why do they occur at the ends of the neuraxis? There are several explanations, most of which go back to the notion of all the other abnormalities that occur in relationship to neural tube closure defects. I think we've all learned that the neural tube closes like a double pull zipper, extending from the middle of the thoracic spine upwards and downwards, but this in fact is actually incorrect. The neural tube probably closes from multiple points, and it's been demonstrated in mice that there are at least 5 points of closure. And neural tube defects are almost invariably related to deficiencies in folic acid, so it's important to take your vitamins. What is the embryology of the notochord, and what is the relationship to the formation of the tumor that we call the chordoma? In the beginning, there is a gelatinous cylinder of tissue, the notochord, which forms the craniocaudal axis for the developing embryo. The notochord is surrounded by the sclerotomes to form the vertebral bodies. 2 adjacent sclerotomes form a single vertebral body, with the basovertebral veins representing the original cleft between the sclerotomes. We also have the myotomes and the dermatomes around the outside. In normal embryologic development, the notochordal tissue is extruded from the vertebral body and ends up as a mass of cells inside of the nucleus pulposus. The hypothesis is that if notochordal tissue remains abnormally entrapped within bone, it doesn't get chemical signaling to prevent the further proliferation, and we end up with an intraosseous mass that is a chordoma. So in the normal situation, the notochordal tissue is in the disc, but not within the bone. Chordomas are typically midline lesion in the clivus and in the sacrum. However, they can extend laterally, dorsally, and ventrally. They're usually very lobulated, heterogeneous, bulky masses. They're almost invariably associated with destruction of the parent bone. They have variable attenuation and signal, but oftentimes are water-like. And within the tumor, we can find bone sequestra and dystrophic calcification. Here's a typical example on the sagittal T2-weighted MR of a large, bulky lesion associated with destruction of the inferior margin of the clivus, heterogeneous with a water-like signal intensity. This gross picture illustrates a similar appearance with a lesion arising from the inferior margin of the clivus. It's a lobulated lesion, and it's still covered by an intact layer of dura. It is an extradural, bulky, lobulated mass. If we look at a different example here, we can see destruction of the clivus, and we can also identify multiple bone fragments within a large nasopharyngeal soft tissue mass. This description and appearance of chordomas has been described for 70 or 80 years. In 1959 at the Royal Society of Medicine, the classic presidential address described the chordoma as having irregular destruction of the affected bone, bursting through the cortex. Flakes of bone may be carried out into the soft tissue of the tumor. The tumor does not generate a new blood supply, and calcification is very commonly seen within the tumor. It is not a bone tumor, and bone reaction and proliferation is not expected. The dura is typically intact, and we can see on these cross-sectional images the dark line that represents the dura, separating this extradural mass from the intradural cranial contents, including the basilar artery and the subarachnoid space. So a classic appearance, a large, bulky midline lesion, bone destruction, heterogeneous, and a water-like signal intensity. Primary chordoma is a much more common lesion in the clivus than metastatic disease. METs constitute less than 1/6 of destructive clival lesions. You want to remember that metastatic disease does not destroy bone. The chordoma does not destroy bone. Instead, both METs and chordomas stimulate bone destruction by overactivity of the osteoclasts and in some cases inhibition of the osteoblasts. So as Mark Murphy always says, there's only two things that can remove bone: osteoclasts and surgeons. Now it's time to head south and talk about chordomas in the sacrococcygeal area. The most common bone tumor in this location is going to be a chordoma. Once again, it's typically a very lobulated and exophytic mass. It has a water-like signal on T1 and T2, and if we have appropriate imaging, we should be able to see internal bone sequestra, remnants from the parent bone that has been destroyed by the lesion exploding beyond the cortical margin. This patient presented with pelvic pain. We can see on the sagittal MR that there is a water-like signal intensity mass involving the tip of the sacrum, and we can see dramatically increased uptake on the PET-CT scan. If we look at the plain radiograph, it's very difficult to see the bone destruction, but we've lost the normal air shadow from the rectum and fecal material. And if we look here at the sagittal MR, we can see this bulky lobulated soft tissue mass coming out of the tip of the sacrum. Paired images T1 and T2 show the typical appearance of a water-like signal being relatively dark on the T1 weighted image and relatively bright on the T2 weighted image. The location of the lesion, the lobulated contour are very consistent with the lesion being a chordoma. Let's look at a few more examples of sacrococcygeal chordoma. We have paired images here with bone window and soft tissue window showing again a large lobulated bulky mass coming out of the tip of the sacrum. We can see here on the MR scan again a soft tissue mass, lobulated. Minimal contrast enhancement is noted, and the lesion again is extending out of the sacral canal and into the adjacent soft tissues. Typical appearance for a sacrococcygeal chordoma. Another example here, we can see this large lobulated bulky mass in the same location. And if we look at the axial image, we can see these multiple large irregular bone fragments within the soft tissue of the chordoma. Again, this goes back to the original description from 1959 of showing the large calcified fragments within the soft tissue mass that is a chordoma. Let's summarize what we've talked about for chordomas. It's typically a bulky midline mass, lobulated or bossulated, almost invariably associated with significant bone destruction. It can be heterogeneous. It may have water-like areas with appropriate signal on T1 and T2 weighted images. We see irregular heterogeneous contrast enhancement. And it's important to remember that a chordoma is much more common than metastatic disease to the clivus.